Okay, now I'm going to talk about the final thing in the acute kidney injury, the management of acute kidney injury. Okay, the first most important thing to manage in acute kidney injury is, yes, the life-threatening conditions. You can't ignore the or postpone the life-threatening conditions. You have to start with them. Okay, let's remember together what are the life-threatening conditions in acute kidney injury. We have, I told you, the electrolyte imbalance. Like what? Like hyperkalemia. The most important life-threatening condition is hyperkalemia. And how to treat hyperkalemia if it is first of all, the hyperkalemia is defined of more than 6.5 milli equivalent per liter, okay, or less than 6.5, but we have ECG changes like tall peak T wave. So if you have a hyperkalemia, how to treat it? You start with reduce potassium intake, then you give insulin plus dextrose, about 5 to 10 units of insulin plus dextrose. Okay, if you have ECG changes, you can give calcium gluconate. Calcium gluconate is very good for ECG changes to stabilize the membrane of the heart and reduce risk of arrhythmia. This is in ECG changes. If you have no ECG changes, it's not necessary to give the calcium gluconate. Then the K-xylate will get rid of potassium. So these are the measures in treatment of hyperkalemia. Also, if you have hypocalcemia, or have treated hypo or hypernatremia, you have to treat it. Okay, if you were unable to treat these conditions, you have to maintain the fluids and the electrolytes by renal dialysis. Okay, but before talking about renal dialysis, I'm going to get back to the other life-threatening conditions which are related to the hydration. I told you in acute kidney injury you may have a case of dehydration or a case of overload edema or overhydration. In dehydration, we treat by a fluid replacement. Okay, in overhydration, we give diuretics, the loop diuretics, furosemide. Okay, in the cases of acidosis due to acute kidney injury, we give bicarbonate administration. So these are the life-threatening conditions: the electrolyte derangement, the fluid imbalance, and the acidosis, and each one with its treatment. Okay, if we were unable to maintain fluid and electrolyte balance, okay, we have to do renal dialysis, or what we call renal replacement therapy. It is not haphazard. Okay, we have some indications for renal dialysis, like if we have blood urine nitrogen above 100, okay, milligram per deciliter and increasing. So blood urine nitrogen above 100 milligram per deciliter and increasing. And actually blood urine nitrogen is a byproduct of a protein breaking down in the body, and I told you how to use this thing to differentiate between pre-renal and renal causes. Okay, now we are talking about the renal dialysis. If we have more than 100 milligram per deciliter blood urine nitrogen, is an indication for dialysis. If we have oliguria that are unresponsive to diuresis, so you have to do renal analysis. You have an overload edema and you give diuretics and it is not working. Okay, so you have to do renal dialysis. If you have hypertension, encephalopathy, patients starting to have some encephalopathy due to the hypertension, so you have to do dialysis. If you have hyperkalemia plus ECG changes, okay, and you give calcium gluconate, you give insulin and dextrose, okay, they are not working, then please move to dialysis. Severe acidosis that you cannot solve with bicarbonate administration, go to dialysis. Severe anemia, okay, so anything of the life-threatening conditions that you cannot deal with by drug, you have to move to dialysis. Okay, remember the blood urine nitrogen also is an indicator above 100, okay, oliguria, hypertension, and so on. Okay, So before doing the analysis, we have to make sure that in pre-renal cases the patient has received adequate fluid, okay, and he is not resolving. In renal causes, we have to ask about yourself, is it about the kidney or about of other disease? Okay, in post-renal you have to do ultrasound. Now treatment of the life-threatening conditions and renal dialysis, you have to treat the underlying cause, of course. After that, if your patient is taking nephrotoxic drug, please stop it, like glucophage, like NSAIDs and other aminoglycosides and other drugs. Okay, stop it and treat the underlying cause. If you have an infection, treat it. If you have an autoimmune disease, treat it. If you have a stone, post-renal causes, treat it. And we have a nutritional support for acute kidney injury. Actually, it's improve the survival of patients of acute kidney injury. Of course, you have to reduce the salt intake because you have an accumulation of salt. Okay, the patient with acute kidney injury is in a catabolism state, so the goal behind giving him adequate nutritional support and appropriate nutrition is to avoid the case of catabolism ketoacidosis. So you give him the appropriate food, enough food, okay, to avoid the ketoacidosis due to catabolism that is the status in the acute kidney injury. So this is how you manage the acute kidney injury in brief talk. Okay, life-threatening conditions, the indications for renal dialysis, BUN, the oliguria that is not resolving, the fluid replacement, severe anemia, severe acidosis, hyperkalemia, hypertension, encephalopathy, and so on. So thank you very much for watching this video. By this I end up the talk of acute kidney injury. I talked about the definition of acute kidney injury, the Reifel criteria, the pathophysiology of acute kidney injury, the categories of causes of acute kidney injury, the pre-renal, renal, and post-renal, the approach, history, physical examination, investigations of acute kidney injury, and how to differentiate between the pre-renal and renal causes of acute kidney injury and the management of acute kidney injury. Thank you very much. See you in the next video.